All right, I think we're at the hour here. Because we have a lot to cover in an hour as people trickle in, I think we can get started. My name is Pat McGann. I'm a pediatric hematologist at Cincinnati Children's Hospital and chair of the AAP section on global health. And I'll be the moderator today. We have three great speakers and a very timely and important topic. I hope to learn quite a bit about PPE in the setting of the COVID-19 pandemic and the global health context. These webinars have been quite popular and successful. There's nearly 150 people registered for today from 39 different countries, and I see the number increasing, so hopefully we have that enthusiasm continue. If you go to the next slide, please. So this is our fifth webinar over the course of the last month or two related to global health practice in the time of COVID. As COVID is changing now from an acute crisis to an undulating pandemic, there are lots and lots of new challenges, and we're trying to hit on these challenges both personally and professionally for people practicing pediatrics across the world. And I think that the topic today is quite timely, certainly as the cases continue to increase in all parts of the world. PPE is an ongoing concern, and I think we need to think carefully about how we're using it and conserving it. And I hope that we can learn quite a bit over the course of the hour today. There'll be a reminder of the next webinar, which is upcoming in August. And I encourage you all to follow along or join the section on global health to get updated on this and to participate. We have this pandemic has allowed us to develop this webinar series that we've been trying to develop for quite some time, thanks to Chiquita Paula de Souza, who's really spearheaded this along with the AAP team. And I think these have been successful, and hopefully people can learn from it. If you have not been able to attend the previous 4 webinars, they are available on the AAP's YouTube channel, which I believe was linked with this invitation. If not, it should be pretty easy to find, or we can circulate that link. Next slide, please. Just as a disclaimer, these are personal opinions from renowned experts who are sharing the best practices in their field and stories of how COVID has impacted our global health communities and partners. These are not opinions that represent the American Academy of Pediatrics, and there are no conflicts of interest to report amongst our speakers today. Next slide. So our next webinar, as I mentioned, a reminder, just in a couple of weeks. We've been doing these pretty regularly, every week or two even. The next one is about maternal and neonatal care during COVID, and specifically we'll focus on how national pediatric societies in global health settings are responding. This will be at the same time, 12 o'clock Eastern time, 11 o'clock Eastern time, my apologies, on August 12th. There will be reminders sent out, and hopefully you all can join us for that. And feel free to spread the word about these webinars to your colleagues, both domestically and globally, or anyone who may have interest. I think these are interesting topics that answer a lot of questions that we have. Next slide. Next slide. So I was going to introduce one reminder before I introduce our speakers. You'll see on your WebEx page, there's a chat box, and then there's a Q&A box. If you have any questions at any time throughout the presentations today, please submit your questions into the Q&A box. As you submit a question, be sure that you're sending it to all panelists and not privately to one person. The Q&A box is where we'll draw from these questions, and we just don't want to miss anything. We are likely to combine all the questions after the 3 speakers have presented their work or have made their presentation, and so we'll combine all questions towards the end and try to catch overlapping themes if there happen to be too many. I'll introduce all speakers at one time here just for the sake of efficiency. Our first speaker will be Dr. Yvonne Bonnie Maldonado. She is a professor and chair of infectious diseases in the Department of Pediatrics at Stanford College of Medicine. She is the vice chair of the AAP's Committee on Infectious Diseases, and importantly, as it relates to this talk, the co-author of the upcoming AAP's guidance on PPE. She will provide a sneak peek of these guidelines and discuss the challenges and considerations into writing this guidance on behalf of the AAP during this pandemic. Our second speaker will be Dr. Amy Benson. Dr. Benson has over a decade of experience as a pediatrician in a variety of global health settings. She is currently a global health corp physician at Baylor College of Medicine, Children's Foundation of Malawi. Dr. Benson will discuss challenges and considerations in formulating guidance for PPE in low and middle income country settings. As an organizer of a BPI network teleconference on best practices, she will share insights around practical considerations when PPE items are not available in country. And our third and last speaker will be Dr. Amanda Burridge. Dr. Burridge has extensive experience in disease outbreaks across the world during her time at the CDC as an epidemic intelligence officer. And she currently leads the epidemic response team and is a pediatrician at the Tuba City Regional Healthcare Corporation on the Navajo Nation in Tuba City, Arizona. Dr. Burridge will share her challenges for procuring and managing PPE at a small rural hospital on Navajo Nation, and will discuss creating PPE guidelines for her setting with limited and rapidly evolving information. So quite a breadth of speakers, and I think we'll learn a lot. I look forward to it. Reminder to ask your questions in the Q&A box, and let's get started. Dr. Maldonado.
Well, thank you, everybody. Good morning, evening, and afternoon, wherever you are. I'm really honored and excited to be here with you today. I know I have a short time to talk, so I will be brief. I just wanted to give you a little bit of my background so you understand what I'm doing here and what I've done before to get to this point. So I'm a pediatric infectious disease epidemiologist. I am the director of infection prevention and control for the Children's Hospital at Stanford in California in the United States. I've been doing that for a long time, and I'm a CDC trained epidemiologist. And so I've been working in global child health for most of my research career, primarily around vaccines and population prevention. And so that has really been the bulk of my work, is how to prevent diseases in large populations, including hospital-based settings in the US and hospital and outpatient-based settings in different parts of the world, including Asia, Sub-Saharan Africa, and Latin America, as well as the US. So I've been a member of the Committee on Infectious Diseases for the American Academy of Pediatrics now for 7 years, and I've been the chair now for 2 years. It's been a really exciting opportunity to work with AAP and with the wonderful staff and all the other experts that we get to meet. And so in the last few weeks, the AAP has really been trying, as you know, to address issues around how to handle COVID-19 in the real world setting, meaning taking care of children, answering parents' questions, and addressing really frontline questions when there are very few data to go by. And certainly that's true all around the world, but I am sure that in the developing setting, it's even harder to capture really good data because of potential lack of resources, for example, to do testing and reporting. So I'm going to tell you a little bit about what we've done here in the US to put our guidance together for PPE. And as you heard from Dr. McGann, we haven't actually approved the guidance yet, but we've worked on it quite a bit. And so I can give you just some high-level considerations that we took, and you'll hear more granular information from my colleagues on this talk today. And so one of the things that we have to do as the Academy, and especially in the Committee on Infectious Diseases, is most of us are pediatric infectious disease experts or liaisons from agencies around the country and around the world who have expertise in infectious diseases. Because of that, we're dealing with large populations that are very uneven, that may have different resource requirements. And most importantly, within the context of this pandemic, we know that the epidemiology of this disease is really, not only is the epidemiology evolving, but our knowledge of the virus itself is evolving from one day to the next, as you all know. We've only known about this virus really for about almost going on eight months now. So we really don't know much about it. We know about its partners and cousins, some of the other coronaviruses, and we try to extrapolate from that, but not all of that is exactly identical. And so when you look as an infectious disease preventionist and an epidemiologist, one of the things we like to look at is patterns of disease. So it's very important for all of you to really try to understand, to the best extent you can, what is the pattern of disease that you're seeing in your region. So whether that's local, whether it's regional, whether it's at the state level or at the country level or beyond. What do you see in terms of the evolving epidemiology? And that must include not just children, but pregnant women and other adults in the community, because really the community will drive, we think, the epidemic in children. More and more we're understanding that that may be the case, that the epidemic is being driven by communities, not necessarily by children directly, but they will obviously could become infected and could contribute to that epidemiology. The other guiding principle that so again, we have to really make some concessions to what if you have low transmission risk, what if you have high transmission risk in your communities, how do you look at that? And that's something that you need to take into account around PPE use, because if there's high levels of transmission in the community, you may need to take more precautions in some settings, and in others you always need to take precautions because they're always potentially universally risky procedures. For example, aerosol generating procedures is an area that we know are probably the highest risk for transmission regardless of the local epidemiology. Whereas community transmission or transmission from mothers and children or parents and children coming into in a clinical setting may be at lower risk depending on how high the community spread is. So PPE for providers and for patients will be guided by epidemiology. Now, the other really important thing that absolutely we really needed to state unequivocally in any guidance, I think we do that, and I think everyone really has to adhere to this, is really to keep in account the fact that everything must be guided by public health guidelines. We can do all of the specific questions about disease and virus and treatments if they are available at some point, et cetera. But we must follow our public health guidelines, and whether those are local, regional, national, or global guidelines, those are really important and must be taken into account. So for example, if there's a guideline that suggests a certain type, so that people should wear masks, then that really needs to be considered very strongly in putting your guidelines together. And for, as you recall, for some time, universal masking was really not mentioned, at least here in the U.S. And in some places it is a mainstay, and others it's not. It doesn't mean that you can't go above and beyond the public health recommendations, and that's really helpful, I think, for all of us, is that we can make recommendations that can go beyond the public health guidelines because they're so uneven from one place to another, but it doesn't mean that we can go below those. So we always need to make sure people realize that they need to go to their local guidelines. And if you are working at a national or a regional level, especially as a local academy or a society, you need to make sure to provide a link or resources for local providers so that they know how to access the local public health guidelines, because some people really won't have the time or the knowledge of how to get to those data. So if you have the data, it's helpful to give updates around PPE requirements for your region, or you can give a link if there's a website that's available for that. I think the other area that's important to think about are challenges related to uneven supply chain. And I know it's extremely challenging for all of us. I can imagine that in areas of with low resources, it's an even bigger challenge. Here in the U.S., as you all know, we've also had initially major challenges in access to any testing. And even today, we are having access issues to testing perhaps not to getting tested, but to getting test results. And we know that the same thing may apply to collecting tests and wearing PPE when people would be collecting tests in practices or in clinics. So ways to address uneven supply chain and what people can do to mitigate that. So for example, if you are going to be taking tests or doing procedures, how can you supply information so that people can do those safely or refer to others who might be able to do them? For example, referring children to areas or to partners who do have adequate PPE to do certain procedures. It's also important to outline what those procedures might be. So what is it that is a high-risk procedure? What is it that is a low-risk procedure that would require certain kinds of PPE? Infrastructure at the practice level is critical. So some of these will be regional open-air clinics. They may be polyclinics. They may be national clinics. They may be private clinics, but all of them will have different infrastructure needs. And it's important to give very high-level guidance on what PPE considerations should be taken given the kinds of practices. So if the practice is small and has small rooms, only has one entrance, there may need to be mitigations such as only allowing sick children, sick visits and well visits at different times of the day or different days of the week, because PPE restrictions may be a problem in certain practices or regions. And then, of course, the main issue here with young kids is that not all children are alike, and children are not little adults. And we are certainly seeing that to be the case with COVID or SARS-CoV-2 infection. And at this time, it does appear, although we don't know for sure, but the data that have been published so far, which are limited and really come from mostly Asian countries, so we don't really know how well the data looks across the rest of the world, is that young children may be at lower risk of symptomatic disease and also may be at lower risk of transmitting disease. That is, it appears that they can, we know for sure that they can become ill, and we know for sure that they can become severely ill, but we have not seen that proportion of children is very high relative to adults. And we also know that younger children, those in particularly under 5 or 6 years of age, appear not to be as highly able to transmit infection as older children and adults. And so the PPE needs may be different in those situations, but those data are evolving. The additional consideration around patient age is ability for children, if you have that capacity, to wear masks. Children younger than 7 for sure is very hard to get them to keep masks on or not to put their hands under their masks. So we try to consider that we allow providers to take young age into consideration, for example, in using additional PPE such as face shields or goggles, if those are available, or other methods that might be available locally. And so I think those are the major considerations that we really took into consideration when we wrote our guidelines. The other thing I want to mention is our guidelines, once they get approved, we're trying to keep them very short. So 2 pages, maybe 3 at the very most, with bulleted information, tables when you can have them, figures are very helpful as well, and links to resources so people can find out additional information, because this is an evolving pandemic and our PPE guidance is evolving as well. So those are some of the issues that took our time as we prepared our guidance, and we are hoping to see those published as they get completed and reviewed by our AAP leadership. And I thank you for your attention, and I will turn it back over to AAP lead. Thank you.
Thank you, Dr. Maldonado. That was great. I think this guidance is much needed when we're all kind of scratching our head. And I think this will lead nicely into our next speaker, Dr. Benson. Handing it over to you.
Hi, and thanks a lot for having me here today. So yes, I work with BPI, which is Baylor International Pediatric AIDS Initiative, and we work in the countries seen in green on the map there. Usually I live and work in Malawi, and that's a picture of our clinic. We have the largest pediatric HIV standalone clinic in the country, and we work really closely and right next door to Kamuzu Central Hospital, which is the largest hospital in the capital city of Lilongwe. So Malawi is a small landlocked country in southeastern Africa, and currently, as of yesterday, they had 3,709 cases of COVID-19 and 103 deaths. So BPI's COVID-19 response has primarily been about protecting and prioritizing our healthcare workers' safety. If we can keep our healthcare workers safe, and healthy, we can keep our clinics open and keep taking care of our patients. So PPE is just a part of that. Infection control and decreasing exposure is also really important. So just very briefly, I wanted to talk about some basic infection control measures. People are calling this the golden age of hand washing, and I think it's really true. I think it's really exciting. We were able to get a bunch of those buckets with taps and soap, and you have to wash your hands going in and out of clinic. They're located all throughout the hospital now, and people are washing their hands more than ever. So it's definitely been a positive coming out of this. We were able to find supplies, ingredients locally to make hand sanitizer per the WHO guidelines, and we switched to bleach-based cleaning. But really what we want to talk about is how to extend use of PPE or conserve PPE. So supply chain is definitely a concern in the world and definitely in Malawi as well. So I'm just going to go through the different parts of PPE. Eye protection, for example, there are lots of YouTube videos on how to make your own face shield, and I think they're great. I've made a couple of these out of soda bottles. You need string and soda bottles, which you can find everywhere. You can use binding covers. I put a snorkel mask up there because initially, when this was first starting in Malawi, we have a big, beautiful lake called Lake Malawi with lots of hotels who have snorkeling gear, and we thought we might have to tap into that, but we didn't. At our clinic, in our clinics, we were able to get lab goggles like you see in the bottom left, and that's what we're using now. And I put this picture here to show that this is not just something that's happening in low and middle income countries. This is a man in his living room making face shields out of pool noodles in Las Vegas, Nevada. So it's definitely everywhere that this is happening. Gloves, we haven't had any trouble procuring gloves in Malawi. We can get them locally, but if it were a problem, there are guidelines. Reusing gloves is not recommended, but there are guidelines written for specifically for hemorrhagic fever, talking about how to sterilize gloves or disinfect gloves between patients. So gowns, again, this is in the upper left, you see an article that was in Telegraph. Doctors in India and Pakistan wear bin bags and raincoats to protect against COVID-19. But there in the bottom middle picture are 3 nurses in Mount Sinai Hospital in New York. So this is a problem everywhere. Garbage bags are not as recommended because they tear easily, and anything that tears easily is not going to provide as good of protection. But raincoats and rain ponchos have been found to hold up. In the bottom left, it was a video about firefighters in Virginia extolling the virtues of their new raincoats and how easy they were to clean and easy to put on. But in our clinic in Malawi, what we did was we had a local tailor make gowns with cloth that we found locally as well. If you're going to do that, you should have a cleaning protocol in place to make sure that they get cleaned properly. In the upper middle, you see those plastic aprons. Those are ubiquitous and cheap and easy to find, so they can protect against surface protection between patients over your gown as well as another option. Scrubs and scrub hats. So for head coverings and scrub hats, we were able to make those with a local tailor, and that's her modeling her work there. And in terms of scrubs, you can go to the secondhand clothing market. You can buy a bale of sheets, a bale of jeans, or a bale of medical wear. You don't know if you're going to get all XXL shirts and tiny pants, but it worked out, and we were able to outfit our workers. And the workers in the hospital did the same. So everything we've talked about today, you can DIY, you can do it yourself, you can find alternatives, and masks is the one place where you cannot do that. Currently in Malawi, you cannot buy N95s or KN95s. So that leads us more to try to extend the life of what we have. I'm sure most of you saw that 2013 article in Disaster Medicine Journal looking at would homemade masks or cloth masks stand up in an influenza pandemic, and they concluded that they were better than nothing. So right now, the Ministry of Health in Malawi and we all agree that that's not good enough, and our healthcare workers who are involved in direct patient care are not using cloth masks. So one way to extend the life of masks is to use a face shield over to protect against surface contamination, and that was something that the CDC had recommended. But there are two other ways to decontaminate masks between uses, and idea number one was actually put forward by Dr. Tsai, who invented the N95, and basically it's that you cycle through masks, leaving them time to dry out in between. So you have 5 bags, label them 1 through 5. You wear mask 1 on day 1, mask 2 on day 2, etc., and cycle through them. Idea number 2, so a lot of you probably know UV light is being used, and vaporized hydrogen peroxide and heat are all 3 ways that have been shown to disinfect the N95 masks. At least a couple of months ago, we were unable to find the proper UV light in Malawi, and vaporized hydrogen peroxide wasn't an option. But Jerry and his team at the Global Health Informatics Institute in Malawi did come up with this. So following advice that had been given in the American Chemical Society journal ACS Nano, some researchers out of Stanford had found that if you kept the heat at 75 degrees Celsius for 30 minutes, you could possibly reuse the masks up to 20 times. That since has been changed. I reached out to Jerry and his team. So this, what you're seeing right here, is a picture of the first prototype. They're working on the second prototype. Now you have to get the heat up to 95 degrees. So the second one, they've sourced all local materials in Malawi. And I think this is a really creative, innovative response to a problem, and pretty exciting. So also, I think Dr. Maldonado also mentioned this, but decreasing exposure and then decreasing the need for PPE is also another way to conserve PPE and also protect our staff and patients. So we've scaled down staff with alternating weekly or biweekly schedules, and non-essential staff can work from home. There are some limitations to that I won't get into today. We've done multi-month prescriptions to prolong the amount of time that people have before coming in to clinic, and all non-essential services as defined by the Ministry of Health have been suspended. And then we have, this also Dr. Maldonado mentioned, but we have changed our flow and triage, so all sick patients are seen by a dedicated clinician outside, which also limits who needs to wear full PPE and also limits exposure. So some ongoing challenges that we've had, clearly supply chain challenges with little to no production and price gouging are an ongoing challenge. Deciding how many uses we can get out of equipment that was meant to be single uses is definitely a problem. The CDC has guidance on when to discard a mask, for example, when it's visibly soiled, etc. But if it's not, then how many uses can we get out of it is an ongoing challenge. We need more education about when and how to use PPE properly. How to conserve supply is definitely an ongoing discussion. And this is a big one. How to equitably distribute supply with our partner hospital and clinics when need exceeds supply. So is it fair that we have masks and the Ministry of Health workers, clinicians next door don't? So clearly that's not fair, and we're working together to make it equitable. But knowing that when supply ends, so does programming. And in decreasing exposure and scaling down staffing, we've lost valuable programming, which is an ongoing balance, trying to figure that out and bring that back. All right, thank you. And back to you, Dr. McGann.
Thank you. That was great, Dr. Benson. I think, answered a couple of the questions I had. And just as a reminder for those who may have come late, the Q&A box, I believe on your right-hand side of the screen is where you should submit your questions. We'll get to these after Dr. Burge speaks, so I think we'll have some time for some discussion and questions. So if you have questions, please put them in the Q&A box. And now moving on to Dr. Burge.
You're on mute.
I still think we can't hear you yet, Amanda.
Sorry about that. So hello, I'm Amanda Burge. I'm a pediatrician here on the Navajo Nation in Tuba City, Arizona. Since the pandemic began, I've been leading the epidemic response team here and also helping with the community in Tuba City. So for the next 12 minutes, I'm going to give a brief overview of Navajo Nation and our experience with COVID, review infection control overall and how PPE fits in, discuss key PPE items, and explain our challenges with interpreting guidelines, limiting supplies, supply monitoring, procurement, and our PPE team. So to start, the Navajo Nation is located in the southwestern United States. On this map, it appears in red outlined, and it covers a large area. Technically, it's 27,000 square miles to be exact, which is about the size of West Virginia. It's in the Four Corners region and extends into Arizona, New Mexico, and Utah. There are approximately 180,000 people that live on Navajo Nation in the reservation, and roughly 30% of the population does not have running water or electricity. So while we started planning for COVID in mid-February, we initially hoped that we would have some time as we were a very rural community. However, COVID arrived quickly and hit hard in mid-March, just as cases were starting to spike in other parts of the country as well. The first case in Navajo Nation was identified on March 18th, related to a super spreader event the week of March 7th. And very quickly, our hospital filled up with severely ill patients, and it remained full through May. And now that Arizona is spiking again, we've seen more cases, but they're in a younger population, and we're not admitting as many COVID patients as before. Overall, Navajo Nation, we've had almost 9,000 cases and over 400 deaths since March. So the image on the right comes from CDC and shows how institutional changes are the most effective measures to reduce risk. These changes include elimination of the hazard, to remove or not allow the virus into certain spaces, engineering controls to isolate people from the virus, and at the bottom, PPE. So while we all know that PPE is essential, we must limit risk by limiting our exposure to the virus in other ways as well. In terms of elimination, we created a new COVID sick leave policy and encouraged all employees to stay home and isolate when sick. In terms of engineering and administrative controls, we immediately started cohorting patients into red and green areas. And while we realize it's impossible to eliminate risk in green areas with asymptomatic spreaders, we wanted to group symptomatic patients and those with exposures. On a more global level, we have continued to encourage hand washing and sanitizing frequently and with proper techniques. And we instituted universal masking within a few weeks of the start of the pandemic. While we were concerned about our supplies, given our community spread, we quickly realized that masks were needed to stop the spread between employees in our non-clinical areas. Emphasize safe donning and doffing, offering trainings and retrainings. We've had to insist on donning and doffing monitors for red areas to try to keep their staff as safe as possible with these higher risk procedures. So these are our key PPE items, as you are all familiar with. So in all areas, we recommend at least a surgical mask. Initially, we did not have enough surgical masks, so we encouraged cloth masks in our non-clinical areas, like in the administration building. In the green clinical areas, we recommend a surgical mask at least. And in red areas, we recommend an N95 mask or a powered air purifying respirator, or a PAPR, if somebody failed fit testing, as well as gown, gloves, and eye protection. So from the very beginning, we've struggled to interpret and prioritize multiple conflicting guidelines. Arizona recommended droplet precautions, while the CDC was still recommending airborne precautions if possible. We wanted to be as conservative as we could, but we also had to be realistic about our supply. We also had to decide between FDA-approved versus NIOSH-approved masks, and consider new alternatives that were approved under EUA or emergency use authorization. If something doesn't meet our normal high standards, is that okay for our staff? For example, we frequently have these debates over KN95 masks and whether it was higher risk to use KN95 masks or to reuse the approved N95 masks. We were also offered PAPR's alternatives that were not FDA approved or approved under EUA. So like the rest of the world, our biggest challenge was our limited supplies. In terms of masks, we sought alternatives for our non-clinical staff. As mentioned, we asked administration staff to wear cloth masks. We also noted we had an incredibly large supply of pediatric surgical masks, so we decided to give these masks to patients. While they do not fit or protect as well as an adult size, they provided additional protection for our staff when the donated cloth masks were not yet available. We also had to make reuse and extended use decisions. Without enough surgical masks, we asked staff in green areas to extend use to back-to-back patients and to reuse surgical masks for many days as long as they were not soiled. Similarly, for N95s, we created red areas with extended use PPE where they don before entering the area, see multiple patients, and then doff when exiting the unit. This helped preserve PPE, but it also helped for staff safety to reduce the frequent doffing. We also required reuse of N95s, where staff in red areas would reuse their N95 for days at a time, but use a surgical mask to protect the N95 as much as possible, even though not officially recommended. While it would be safer to rotate masks every 3 to 5 days, leadership felt this was more complicated for our staff to keep track of, especially with locums and volunteers coming through. Although these methods were not ideal, our worst case scenario was to run out of masks entirely. We also arranged for decontamination of our used N95s. Initially, we looked into setting up our own system, but ultimately we were able to use the decontamination services of a large nearby hospital in Flagstaff, Arizona. For gowns, we tried to procure cloth gowns. However, since we were unable to order them, we tossed all the cloth gowns from the decades past. We developed a sewing team. This team was largely made up of dentists and their staff, and they were able to sew 300 plus gowns over the course of many weeks. And then we also had to implement laundry and allocation plans to accompany these new reusable gowns. We tried not to reuse gowns, but we do have extended use for gowns in red areas similar to the N95. So from the beginning and to this day, we struggle with monitoring our PPE supply. PPE was distributed in departments across the hospital. In order to get an accurate count of supply and usage, we consolidated all the PPE distribution to one centralized room. Together with a sign-out sheet and monitors, this allowed us to calculate usage rates by department. We continue to use the system to monitor use and try to project our upcoming needs as we start to reopen clinics. We've also struggled with ordering and monitoring new deliveries. Some supply companies offer allocation, which means we can get a certain number of boxes of gloves, for example, every month, but it does not come automatically, so we still need to request these deliveries. We've placed many orders with new vendors, and it's been a challenge to confirm quality of ordered items. In the number of cases, we've had to cancel our orders because the timeline was significantly delayed or the items never arrived. We were lucky to receive many donated supplies, but we also had to check these donations to make sure they met our needs and our standards. And lastly, given the many donations and large orders, we now struggle with storage of these supplies and are looking to build a new warehouse to store and organize these items. Additional challenges with procurement include financing PPE purchases. Despite urgency, we had to obtain permissions of senior leaders, which took some time. We also needed to confirm that cash or purchase orders were possible, and we ran into restrictions ordering directly from international companies. Most importantly, it seemed like we were taking on risks at the standard for ordered supplies. Not a local Navajo example, but my home team, the New England Patriots, brought back 1 million KN95s for the Boston area hospitals, but ultimately it felt that these did not meet the standards. So with all these challenges and the reasons mentioned, the timeline for procuring additional PPE supplies was never as fast as we had hoped. Lastly, PPE oversight has required a lot of time and energy. Given all the moving parts, we quickly realized we needed a team and an email list to coordinate these efforts. The team includes a lead from dental, since their clinics have been closed, representatives from multiple departments, finance, and general services. We've had regular calls, initially 3 times a week and now once a week, walking around to see what's actually happening in light of our recommendations. This team has also helped arrange training, arrange the layout of donning and doffing areas, and the signage as well. So it's been a large team effort, and thankfully our supplies have improved over the past few months. And we're now working on stockpiling at least 3 to 6 months of PPE, assuming that we will have more COVID surges and that the supply chain will continue to be broken for many months to come. So thank you, and I'm happy to answer any questions. Back to you, Dr. McGann.
Great, thanks. That was really helpful, and really 3 different perspectives, I think. That was really a great 40 minutes. And we have some time for questions and a lot of chatter in the Q&A box. I encourage you to continue to ask those questions as you think of them, since we have our speakers in a bit of time here. One question to start, I'll direct it to you, Amanda, since you mentioned the most about N95. There's a couple of questions about N95s, one that mentions that N95s were not intended to be used for more than 4 hours, and asked about R95 or P95s, which are oil resistant, easier to clean, and intended for prolonged use. A second question asked in cases where N95s or K95s are limited, is a cloth mask with layers, perhaps a middle layer with polypropylene, a reasonable alternative, or just a face shield if you have nothing. This is my question too. Amy, you might want to speak. You mentioned that cloth masks were not recommended for clinical settings, but if you have nothing else, is it, what do you guys recommend, or what are you doing, I guess, on the ground?
This is Amanda. I think it's a good question. I think we've struggled because there's not too much data on the alternatives in terms of what is officially recommended. We also tried to maintain the highest standards possible for our staff, knowing that we didn't want to put people at risk if we could avoid it. But I think those decisions of is 6 hours or 12 hours better than using a cloth mask or using a surgical mask, I think those comparisons, that data isn't available, which makes these decisions really, really hard. I think there was some evidence that prolonged use was okay. And so, certainly people were doing that around the world and around the United States as well. And so that was sort of, if people were doing it and that was what we had, that was what we opted for. But I don't know much about the P95s, and perhaps others do.
Yeah. Oh, no, go ahead.
Yeah, go ahead, Amy.
Okay, yes. Sorry about that. So I agree with Amanda. Basically, we want to do everything we can to keep our healthcare workers safe, and what's the standard to do that? We have not had to make the decision to use cloth masks because right now we have enough other kinds of masks, but we are extending the use quite a bit. So we are opting to use the N95, but probably for about a week. But as I said, there have been a few articles now looking at if cloth masks are effective and what their efficacy is. And so if it's better than nothing, maybe we'll get there. But at least initially, when this first happened in Malawi, a lot of the healthcare workers and nurses were going on strike because they didn't have proper PPE. So for them, the decision was not to work at all if they didn't have the proper PPE, which I think it's always a balance to try to figure that out. And I don't have the answer. Yeah. Sorry, Dr. Maldonado, did you want to say something?
I think we all have the same, we struggle. I work in a pretty large tertiary care or quaternary care hospital where virtually all of our patients are immunocompromised and or undergoing aerosol generating procedures. So we have made this decision that yes, everyone, there's universal masking in our hospital of, over 15,000 employees through the whole healthcare system. And we're also universally masking patients. And we're only allowing one visitor because the risk of community transmission obviously is an issue. And we want everybody to be safe. So obviously that burns through a lot of PPE. And we have had to transition from the usual medical N95s to others, and also to reuse of N95s. What I would say about those things is we're actually also starting to look at other variations on N95s, but we are really trying to prioritize the N95s for aerosol generating procedures, for example, intubations and nebulizers. That's the other thing I wanted to mention. I don't know if anybody talked about this, but or thinks about this, but when you're doing nebulized treatments for children, those can actually be quite risky, we think, for providers. So we're actually either asking people to use PPE, and again, this is not the AAP guidance, this is my own personal hospital guidance, but most people are doing this now, at least here in the conventional U.S. hospital setting when possible, is getting away from nebulized treatments altogether if you can, but if you have to, considering that to be an aerosol generating procedure. And if you can get away with it, using metered dose inhalers or other ways to treat kids so that you don't generate aerosols in the room while they're breathing out. So I do think that there's some concern around different kinds of N95s. And one thing I would recommend is communication with the staff is critical, because when one group sees another group wearing a different piece of equipment, they start worrying that maybe their equipment isn't safe enough. So one of the things that we try to do is have as much as possible a uniform policy, or if we don't, if there's differential use, we try to explain that it's a risk-based approach so that people understand that they're protected. And I will say that in the children's hospital, where we have, obviously we're taking care of COVID patients, I personally am, as we all are probably, I'm taking care of adults and children with COVID right now, actively symptomatic, and we have not seen any transmissions in our hospital to healthcare workers or patients or staff, our families, if proper PPE is worn. And so that does not always need to be an N95. It can be a surgical mask. And surgical masks of all kinds can actually, as long as they're certified by the company, can actually be quite effective as long as the exposing individual is very careful. And where we have seen breaches, that is exposures and potential infections, has been when people take their masks off to go out and eat. And that's important too. That's a kind of a corollary, is that you're very careful in the hospital, but when you go out to eat, everyone wants to be social, and we understand that. But when you do that, you need to make sure you stay far apart, because we've seen what happens is people get together and they want to de-stress and hang out together, but they still need to stay apart, because they can, during eating their food, they can actually wind up spreading. So again, the point is that the type of PPE is important, but it's also important to even use minimum PPE in as efficient a way as possible. And there's lots of good evidence, especially asymptomatic individuals will be less likely to transmit, all things being equal, and even using low-level PPE or masks.
Great, thank you. There's lots of questions. Hopefully we get to some of them in the next 10 or 12 minutes. One question that I thought was kind of a good broad question that perspectives would be helpful on, I think we're all asking ourselves this wherever we are, is have we learned anything about PPE preparedness from this pandemic, and how would we have done things differently if we knew this was going to happen? Or what can we do to prepare for the next time this may happen? Maybe if each of you could give just a sort of short blurb in each of your contexts about, if you're talking about it at your institution about preparing, or stockpiling is the right word, but just discussing how to prepare appropriately.
So we did have a surge plan in place. We have an incident command center that we stand up for any event, whether it's flu or, I don't know, mass casualty events. And so we do have stockpiles, but I don't think any of us could have prepared for the ubiquitous nature of this particular epidemic. I do think what it shows us is that our supply chains are always unstable, and could become unstable, and are at risk because of the weakest link. So if you don't have enough pipettes, for example, you can't do PCR testing. If you don't have swabs, you can't do PCR testing. But the masking and hand hygiene, I think, are probably, in some ways, you can always put something together to cover your face. And whether it's, an N95 or not, I think versus a surgical mask versus a face covering. We know that there are, as you heard, there are data looking at, what works better, what doesn't work as well. It's all theoretical. We don't really know in terms of real transmission because nobody would really want to do those trials yet. But we do think that some degree of covering is better than nothing. And I would, if we had to plan for the future, or we always do plan for the future, we would try to make sure we risk stratify which of our most protective equipment should be going to the highest risk procedures. So identify high risk procedures first, and then try to save the PPE that's needed for that, and then try to utilize other PPE. And the other thing that we learned is that unfortunately, it's really just a matter of people having access to good supply chains around the world, and not everybody has that. So I think we need to empower a lot of our regional and global partners to really start to think about how they can ramp up. So 3D printing is really important, but then you run out of polyester for that or other nitrocellulose. So every single supply chain manufacturer needs to really think about how they can help us for the next time, because I can guarantee you there will be a next time.
Yeah, those are really important points. Before I hand it off to Amy and Amanda, if you could put into context also another question that came through, not only about preparedness, but in your current context, equitable distribution or ethical distribution of what's available. Even in the lowest income settings, there's certainly those with resources and those without, and certainly you want to avoid using all the PPE for those with the resources. And have you thought about that? Amy sort of alluded to it in your own setting. So if you guys, in your last, or Amy and Amanda, if you could comment about not only the preparedness for the future, but also the ethical context around using the limited supplies.
Sure. Hi. So in terms of being better prepared, I think Dr. Maldonado is exactly right. We're pretty limited, and especially I would say in Malawi, we're limited by what we have available locally. So ideally, we would all have a 1 month supply. Once we can get a 1 month supply, we would have things in order to have that available. So if this were to happen again. And that's possible once things calm down. I think we could do that. In terms of equity, it's really working closely with our partner hospital, what needs assessments and burn rates, and being transparent about what their needs are, where their donations are coming from, and having it very clear and written down. Amanda mentioned about how difficult it was to really monitor how much they have, and having one stock coming out now from one stock room and signing in and out. And when you're also involving the hospital and other clinics, it makes it harder to figure out where everything's coming and where everything's going. But the way we've been doing it is we have a team, a senior management team, and everyone is involved and trying to have a needs assessment and understanding what everyone's needs are, what we have. And I think also trying not to hoard and stockpile. So it's really tempting to say, oh, well, we need 6 months, but you can only have 1 month. But really, what's your basic, what are you willing to have? So if we can all have 1 month and have everyone have 1 month instead of we have 6 months, you have one, I think that's also a part of it.
Amanda?
Hi. So yes, I agree with a lot of those things. So I think in terms of preparedness, I think assessing the stock, and I think if it happens again, we have a better sense of how do we do this and how do we centralize. And so I think that was really helpful and would be essential going forward. I think establishing different vendors. So we had, I think, one vendor, and I think creating new vendors was hard. So vendors prioritize their existing clients, and so potentially having multiple chains of supply available, even though all of them are essentially broken, but that might be helpful going forward. And then I did mention the stockpiling, and it's hard, and I think that is an ethical issue of, if we have 3 to 6 months supply, we'd rather have that, we rather would have had that at the beginning than be where we were. But at this point, are there other places that don't have stockpile, and is that unethical to be I guess hoarding it in some ways. But I do think that for our own population, that's important. Also, we are technically a tribal organization, so we're tribally operated, and IHS sites are the other sites on the Navajo Nation. And so we were able to order directly faster than the other sites, but at the same time, they had more channels coming from IHS directly. And so how quickly can we shift supplies? And I think that might be true for the United States as well. Like, we were hit hard in the beginning and didn't have PAPRs and didn't have various things. And other larger hospitals in big cities likely had supplies because they had teams that were preparing for this. But there wasn't that sort of way to shift things back and forth. And I think that potentially helped sort of the ethical issues that we've been struggling with. Great. So only 5 minutes left here. Maybe it's time for one or two more questions. There's one theme that kind of overlapped a bit that hopefully one of you can address, was really about disinfecting masks. And there were questions about specific ways to do that, using alcohol or, oops, I lost my question and answer box. But basically the idea of the appropriate, or I guess best way to disinfect masks if they're going to be reused. Maybe Amy, are you guys doing that or recommending that?
There. Alcohol is not recommended. Soap and water is not recommended. There are pretty there's pretty specific guidance on what is recommended. And right now, really UV light and vaporized hydrogen peroxide and heat in an oven, and those are the 3 ways right now that are recommended. But washing your mask disintegrates the fibers that you need. So yeah, it's not recommended.
Okay, and a couple of quick hit kind of clinical issues, maybe Dr. Maldonado could answer. One was about whether you needed to do deep nasal swabbing in a negative pressure room with full PPE. I don't believe so. And another question was about PPE when caring for pregnant women in labor, which is an aerosol generating event.
Yeah, so that's, I think, up for discussion. So I think the ACOG has kind of laid out some guidance around labor and delivery, and whether that's truly an aerosol generating. I think most of it's mixed. I'll say even at our institution, some services are wearing N95s and other services are wearing surgical masks depending on what they're performing. So the OBGYNs are closer up and wearing N95s. Some of the pediatric team there to take the baby are maybe wearing N95s if they're a known COVID positive mother. And so, yeah, so that's still mixed. I don't think that we have any kind of final guidance there, whether or not labor and delivery is truly an aerosol generating procedure or not. I think it's up for, I mean, certainly it's a droplet exposure, that's for sure. And so the other thing that I don't think we talked a lot about are face shields. And at least here, for us, face shields are really inexpensive. And as you saw, you can make your own toggles. And it's really important in situations that we don't think about, for example, with young children who are crying and maybe yelling or screaming because they're getting a vaccine or something like that. We always know that children don't handle secretions well, especially young ones. So eye protection of some sort, even glasses or makeshift goggles or a face shield, can be reused and disinfected and wiped. What was the first scenario was, taking the N95. Yeah, usually if you're doing a deep NP, people can cough and sneeze on you when you're taking those. So generally that is N95 and if possible gloves and a gown. Because it's a pretty deep swab and people can sometimes gag or cough, sneeze, etc. But it does not need to be in an aerosol generating room. We tend to do them outside. We have a tent where we do all of our swabs, or we do them and even in the emergency department, we have tents outside because it just helps to preserve any of the real airborne isolation rooms.
Okay, great. I think we're unfortunately out of time. What I might do, since there's some lingering questions, we have a listserv within our section. Hopefully many of you are members of our section. If not, I encourage you to join. and perhaps we can answer some of these through the listserv or create a little discussion there. But I appreciate all of the active engagement. We had, I'm not sure, close to 100 people at one point. And save the date here for the next webinar here, which I actually think is 8 a.m. So stay tuned about the time, but it's definitely going to be August 12th, and it's going to be addressing maternal and neonatal care. So thanks for everyone who's joining. Thanks to the participants and the panelists for imparting their wisdom and experience, and we'll see you next time. Thanks.
Thank you.
Thank you.
Bye-bye.